Hello, my name is Johannes Kieding. I am a psychotherapist, and I'm going to talk to you today about a model of psychotherapy that I am really excited about, really passionate about, and my hope is to impart some of that enthusiasm, if not some knowledge, about what this model is all about. So this is going to be a broad overview. This is a psychodynamic perspective. So a little bit about me. I was exposed to ISTDP, which is short for Intensive Short-Term Dynamic Psychotherapy, back in 2007. Actually, on the receiving end, I was the client. It turned out to be life-changing for me, hugely helpful on a personal level. I have been in audiovisual training, which is fancy for I have, with my clients' permission, video recorded my work and reviewed it with an expert in the field, namely Marvin Skorman, and we've done that since 2012, 13 or so. I have well over 500 hours of that kind of training and supervision under my belt. I have met with Dr. Davenlu back in 2012 and 2013 at his international symposiums in Montreal. It was really inspiring to see him and meet him and talk to him and see his work. And a few years ago, I have started training other therapists or interns, students in the model. We are going to briefly just acknowledge, more so than actually look at, the evidence base, a little bit of the history, some of the contraindications of the model, and then I want to talk about some of the key concepts, which is more where the meat and substance will be. This is a model that can affect character change, not just symptom relief. That's an important point. So a little bit about the name. So we call it intensive because the aim is really to help our clients experience their true emotions and feelings in a fulsome manner, as intensely as possible, unless a graded format is warranted. More on that later. We call it short term because we try to do this as quickly as possible. Now a caveat though with this short term, there's no arbitrary end date that we set, and so short term is relative. It's really short term relative to 10 years on the couch. So accelerated is the term that I actually prefer. I think it's more apt. The idea is that we try to accelerate the treatment, but there is no arbitrary end point. The work is dynamic because it involves working with unconscious forces, psychic forces, thoughts and feelings, emotions, sensations, impulses, hopes, desires, attachment needs, individuation needs. And it also involves working with what's called transference reactions, which is the unconscious act that we all engage in of importing and superimposing past templates of unresolved feelings and conflicts and relational dynamics onto our present circumstances and relationships. The primary goal of this model is through collaboration and always with the client's permission and at a tolerable pace, helping our clients overcome internal resistance to experiencing these warded off emotions and other psychic material, fantasies and what have you. I want to say that it's a very adaptable model. It can be adapted to couples work and work with youth and teenagers. It's not meant to be applied in a rigid fashion. In fact, when I saw Dr. Davenlu and I saw his work, I was really struck by how creative and intuitive his work really was. Now, in no small part, thanks to the work of Dr. Alan Abbas, there is a substantial evidence base behind this model. So it's empirically supported. I believe there are over 50 plus studies, many of them randomized controlled trial studies, which obviously is the gold standard when it comes to research. And essentially the outcome data, as I've understood it, shows real efficacy with a wide range of psychological and psychiatric disturbances. The whole garden variety of anxiety conditions and depressive disorders, and but really the full range, not limited to that, but the full range. And there's a link here where you can look at the evidence base yourself. The founder, his name is Dr. Habib Davanloo, a psychiatrist from Iran. Freud discovered the unconscious. Davanloo discovered how to work with it. It's a very poignant, very significant quote by Dr. David Malin. So what Davanloo discovers is that the catalyst of not just symptom relief, but actual character change comes through, in part, what he calls unlocking the unconscious. It also comes through restructuring and these other things, but more on that later. The idea here is that the visceral experience of previously avoided emotions and other psychic material, the skillful application of the method unlocks a force that he calls the unconscious therapeutic alliance, which is that force in all of us and in our clients and patients that strives for health and freedom. This force, this unconscious therapeutic alliance, it comes out during sessions when the force has been sufficiently liberated due to the neutralization of defense mechanisms or resistance. And we recognize it through spontaneous communications and body language that it essentially is directing the therapist to focus on the areas that need to be addressed, that remain unresolved. Now, Frida Fromm-Reichmann, a brilliant psychoanalyst, she has been quoted as saying, "The patient is in need of an experience, not explanations." Very significant, very poignant. It points to that the model is essentially an experiential kind of psychotherapy. So it's not a therapy where we're only talking about things in the abstract or getting psychoeducation and receiving information. As helpful as all of those things really can be, from an ISTDP perspective, it's not enough to generate real fundamental and deep healing, psychological healing and change. Historical backdrop. Davanloo was trained in psychoanalysis proper. He allegedly grew very frustrated with its inefficiency and length. So 10 years on the couch with perhaps little to show for it, it just didn't wash, right? So he came up with ISTDP as a way of addressing what he saw as these problems in analysis proper. Now, he agreed with Dr. Sigmund Freud that resistance, right, resistance is really the main obstacle to psychotherapeutic movement, recovery, and healing. And resistance is really what happens when the patient's defense mechanisms congeal and form a palpable wall or barrier between the patient and the therapist, and sometimes even between the patient and herself and her inner life. So that is what resistance refers to. And the function of resistance is cutting off awareness to painful, scary, taboo psychic material, especially emotions and impulses. Now, where Freud, Sigmund Freud, saw resistance, and felt pessimistic, Davanloo sees the forming of resistance as a sign that important unresolved areas are being approached. In other words, an opportunity. And he found a way of working with resistance where some will argue that Freud himself actually failed. Now that might be up for debate, but that's what I have learned. Now a little bit about Sigmund Freud and resistance. I like to say resistance for some reason. So I'm going with that. So yes, in 1914, Freud has been quoted as saying, removal of the resistance is the analyst's primary task. 1926, the unconscious sense of guilt represents the superego's resistance. It's the most powerful factor and the most feared by us. Okay? It was quoted saying that in 1926, actually in one of his books. 1937, for the moment we must bow to the superiority of the forces to which we see our efforts come to nothing. 1940, in warding off this resistance, we are obliged to restrict ourselves to making it conscious and attempting to bring about the slow demolition of the hostile superego. So it's clear that towards the end of his career, Freud felt pessimistic about the prospect of effectively treating highly resistant patients. Now, Davenlou and resistance. Here's a quote. Davenlou has been quoted from one of his books here, saying, quote, in the classical psychoanalytic technique, resistance is a serious impediment. In my technique, it is to be welcomed as an indicator that painful conflicts are not merely being approached, but can be brought to the surface and resolved. Each time resistance is penetrated, there is a marked and unmistakable increase in the strength of the therapeutic alliance. Now, the influences. Eric Lindemann, he worked with survivors of a nightclub fire that occurred in 1942. He essentially studied PTSD reactions. He saw crises as an opportunity. He found that the psyche of people in a crisis was particularly fluid, and he saw this as an opportunity to effect real meaningful psychological change and healing. So this inspired Davenlou to come up with his method, which actually induces an interpsychic crisis by intensifying the patient's internal conflict between the wish to get better on the one hand and the wish to avoid painful psychic material on the other hand. Another influence was Alexander and French in 1946. They were known for short-term psychodynamic work. I believe they were the pioneers of that, actually. They advocated for an active stance on the part of the therapist. They advocated for a real focus on the here and now. And they coined the term the corrective emotional experience. Now, there are some contraindications. Clients in crises, imminent danger, due, for example, to a violent or abusive partner situation, refugees who have just fled violence. So stabilization work, safety planning, and other supportive forms of therapy can take priority in these type of scenarios. Think Maslow's hierarchy of needs. I don't remember where I heard this, but I heard it from someone. You don't attempt an archaeological excavation in the middle of an earthquake. So psychotic conditions such as schizophrenia, a direct focus on affect can be too much for this population. So that's a contraindication. However, you can still work cognitively in a very graded format from a psychodynamic frame. That's still possible with this population. I do it, in fact. Active substance abuse, another contraindication. Serious adult antisocial behaviors, certain life-threatening psychosomatic conditions such as ulcerative colitis, those unable to function without constant support, clients whose cultural preferences include not being autonomous, but instead wish to forego individuality for the sake of the group. The model really is so much about helping people take charge of their lives and stand on their own 2 feet, not to deny dependency needs, attachment needs, but really those who wish to forego the process of individuating may not be well served by the model. Then developmental disabilities, people not voluntarily in treatment. Autism, I believe, is difficult with this model. I think the jury might be out. There's no research that suggests efficacy with autism when it comes to ISTDP, and I've had sort of a hit and miss track record working with people on that spectrum. Individuals not interested or little motivation in doing in-depth uncovering type work, they're not going to be a good fit. This requires a strong motivation. So there are essentially three components that comprise ISTDP, and they consist of one, a metapsychology, in other words, a theory of what creates mental health and psychopathology, and a technique, Devin calls his technique the central dynamic sequence, and then an assessment procedure where we have certain markers as therapists that we pay attention to, where we assess essentially ego adaptive capacity, which helps us understand the therapeutic needs of our clients. Some of the key concepts, right? So metapsychology. I call this the anatomy of the wounded psyche. It's very important, right? At the very center, there's the need for attachment, for bonding. When attachments, relations to key figures growing up are ruptured or severed in one form or another, that unleashes a whole cascade of psychic responses. Pain, rage, and then we also see sexual feelings and guilt and grief, character resistance, and then the outer shell, which is that resistance against emotional closeness, that barrier or that wall. Triangle of conflict and person are important concepts, important components of the metapsychology. The triangle of conflict is essentially intrapsychic causality, that feelings and impulses that at one point were unwelcome or punished mobilize anxiety, which then goes to defense mechanisms. The client utilizes, often unconsciously, defense mechanisms aimed at trying to manage that anxiety and push away the scary or painful feelings and emotions. And this is incorrect, by the way. Whoever, I got this from the internet, but whoever wrote guilt and shame in the anxiety corner of the triangle is incorrect. That would actually be, shame would actually be under defense, and guilt, if it's genuine guilt, it would be under feelings. If it's defensive guilt, self-punitive guilt, that would obviously be in the defense corner. And then the triangle of person, where we have people in the patient's past life orbit, people in the patient's current life orbit, and then the therapist or the transference, therapist/transference in the other corner. And knowing where our clients are on these two triangles is really the key to being an effective ISTDP therapist. So then the assessment portion, right? We're assessing ego adaptive capacity, and what that means is that ego adaptive capacity is essentially our client's ability to clearly see and assess and respond adaptively to both internal and external demands and realities. An accurate assessment or psychodiagnosis of this ego adaptive capacity, it clarifies the therapeutic needs of the patient and therefore the therapeutic task. Essentially, we're looking at ego strength versus fragility. That's the key thing we're looking for. We are continuously assessing ego adaptive capacity throughout the sessions. We are always assessing the patient's response to our interventions. It is an intervention response model. And it's really the client's response to pressure that indicates the ego adaptive capacity and therefore the therapeutic task. So for example, if we're just shooting the breeze with our client, that's not going to give us an accurate psychodiagnostic picture. So it's really in response to pressure. Pressure is needed, right, to clarify the ego-adaptive capacity. So what we are assessing really has nothing to do with the DSM, those kind of diagnoses. That's not what we're dealing with here. Instead, the domains of assessment, we look at channels of anxiety discharge, and what Dr. Davenlew discovered is that there are mainly 3 of such channels of unconscious anxiety discharge. The one is in striated muscle tissue. So if the client is sighing, meaning that the intercostal muscles here pressing on the diaphragm are channeling that anxiety and getting discharged in the sighing, or hand wringing, or tension of the voluntary muscle tissue. That's one channel. Another is smooth muscle tissue in the GI tract, diarrhea, irritable bowel type complications are indications, queasiness, nausea. And then the third channel, which is cognitive perceptual disruption. That's where the clients get cognitively disorganized, confused. They have a hard time keeping track of their thoughts. The mind can feel like it's in a hurricane. And they can even have blackout experiences where there are lapses in memory. So if the striated skeletal muscle tissue is containing anxiety, in other words, there is signaling in the voluntary muscles, if that's where the channel is going, that's a sign that the patient is not going to come apart at the seams, it's not going to decompensate, and it's a green light that the client can handle and withstand the intensity of the standard format of the model. Now, a client might be in striated signaling, but at a certain threshold, it might go to repression. It might go to a discharge in the smooth tissue. There could be breaking out in hives, or they get queasy and nauseous. And that's a sign that you have to back off. At that point, you have exceeded the threshold of tolerance, that window of optimal anxiety, right? So you've gone above that. Same if the client goes into cognitive perceptual disruption. So it's really not therapeutic. When that happens, it's a sign that you have to bring the anxiety down through recapping, cognitive recapping, or some other method, until, again, the anxiety is being contained in the skeletal muscle tissue. We are also looking at the types of defenses that a client uses. Are they mature? Are they regressive? Are they ego-dystonic? Are they ego-syntonic? Is reality testing intact? Are they psychotic? Are they not? We're looking at their motivational system. How motivated are they to actually get better? Rather than, say, for example, just be taken care of and be soothed and feel better for the moment. So the motivational system is really a very, very important domain of assessment. We obviously look at the degree of resistance, in other words, how invested a given client is in avoiding repressed emotions, cut off feelings. People are generally low, medium, or high resistant, depending on the area that is being addressed. So you might be low resistant when we focus on your father, but when we suddenly switch focus and focus on your mother, you might become high resistant. And so it's that sort of a thing. It's sort of a moving target sometimes. We look at self-reflective functions. Is the client able to reflect on their own experiences in a psychologically minded manner or not? Can the client differentiate their feelings and their anxiety from the strategies that they employ in order to manage anxiety and push away their feelings? In other words, their defenses. We're also going to be looking at to what extent the client recognizes their own role in their own difficulties. We are looking at the client's ability to do their own part in the dialogue, their ability to share meaningful information. Are they bouncing back, or are they collapsing into passivity? And we also look at underlying themes related to the triangle of person. It could be the theme of rejection and abandonment, not being taken seriously, but whatever the themes are that precipitate emotional reactions are really paramount to really get clear on and reflect back to the client. All right, and then technique. So nothing in ISTDP is done willy-nilly. Well, I think I'll try a little bit of this today or a little bit of that today. All interventions have a rationale, and they flow from this interactive diagnostic roadmap that Dr. Davenlu created. It's an intervention response model. The technique itself is the central dynamic sequence. So a little bit about the connection between assessment and technique. So it's important to understand that the therapeutic task is very different with a client with low ego-adaptive capacity and signs of fragility versus a client with high ego-adaptive capacity and ego strength. So ego strength means that the client can tolerate the experience of anxiety and other intense emotions. Essentially, they can tolerate the de-repression of their unconscious without decompensating, without coming apart at the seams. Fragility means that the client cannot tolerate higher levels of anxiety and emotion without decompensating, without falling apart. And this manifests as smooth muscle discharge, cognitive perceptual disruption, and utilization of regressive defenses, for example, weepiness or projection with shaky reality testing. When we encounter signs of fragility, and by the way, people are more than one thing. They might be sturdy at a certain level of intensity, a threshold, but then at another level of intensity, there might be the fragility that comes out. And so don't think of this as categorical or black and white. When we're focused on a client's father, they might be fine and not highly resistant and open and able to experience certain feelings. And then as soon as the focus goes to the mother, we could look at a totally different animal where suddenly there's this fragility and what have you, right? So people are more than one thing. Keep that in mind. So all clients with a character structure that's organized around a psychotic or borderline level of functioning are by definition fragile and require a very graded approach. Here, we're actually strengthening the repressive barrier rather than weakening it. Here, anxiety is what Davenlu called ripping. It's intolerable. And so we really have to actually choose and pick and help the client go with the healthier defenses and move away from the unhealthier defenses. But essentially, we're trying to strengthen the repressive barrier rather than neutralizing it or weakening it. With the fragile client, the task involves capacity building, and that consists of one, a desensitization method, which is essentially a form of interpsychic exposure, where we introduce, say, a level 1 pressure. So how do you really feel now towards your mom as you think about the way she abandoned you? The client reacts to this, goes above threshold, and we back off. Right? We change the subject, or we help them cognize and self-reflect and bring the anxiety down. And then a minute later, whenever the anxiety again is contained in the striated tissue, we introduce a level 2 pressure. Again, but now let's go back to your mother, and then we back off again, and the next time we introduce level 3 pressure. And so slowly what that is doing it's desensitizing the client's system so that they can eventually tolerate higher levels of intensity of feeling and anxiety. We also, in the graded approach, restructure defenses. That is, we replace regressive or unhealthy maladaptive defenses with higher order defenses. So this includes turning the client against the maladaptive defenses, helping them see how those defenses are really working against the client's best interest. They're hurting the client. So restructuring defenses very much includes helping the client turn against the maladaptive defenses. Now, with non-fragile patients, the vertical approach often makes sense. This is where unremitting pressure and challenge takes place. And this we do in the context of a strong conscious therapeutic alliance. So it's not enough if a patient, say, has the ego strength, is sturdy, there's no signs of fragility. They might be able to tolerate an unlocking of the conscious, but if it happens outside of the context of a trusting relationship, of a strong conscious therapeutic alliance that can help the client really make sense of their experience, then it's typically not all that therapeutic. But again, here, right, assuming this conscious therapeutic alliance is in place, the therapeutic task is to help the patient rapidly identify the maladaptive defenses that impede their progress and then turn them against those defenses. Face underlying feelings, emotions, impulses, and all of that, instead of avoid them with the defenses, and then putting those feelings into perspective. Now, the graded approach is moving in this direction, same task, but at a much, much slower pace, depending on how graded you need to be. One way that can be helpful in helping people understand ISTDP is to look at what an ideal psychotherapy session might look like, an ideal course of treatment. So in an ideal scenario, the patient comes in, they declare a psychological problem, they can quickly see that avoiding their feelings and emotions perpetuate this problem. They face the feelings instead of avoid them. They work through them, they put them into perspective, they take charge over their lives, they resolve their symptoms, and off they go. That never happens because defense mechanisms get in the way. Here's an overview, by the way, of the central dynamic sequence. Phase 1 involves inquiry. This is which we try to understand the nature of the problem symptoms. We're looking carefully at whether or not the patient can share meaningful, significant information with us, whether or not they're doing their part of the dialogue or not. The next phase is that of pressure, challenge to the defenses, transference resistance, direct access to the unconscious, and then systematic analysis of the transference, and then a direct view of what Davenlu calls the core neurotic structure. A typical sequence of interventions. Again, inquiry phase, that's always number one. We identify the problem and the patient's goal. We are going to ask for specific examples of the problem from the client's life. We're going to be identifying emerging themes related to the patient's problems. Relationship problems. Issues around abandonment. Depressive episodes precipitated by yada, yada, yada. Okay. And then at some point along this process, we're going to be asking about feelings. So here's what happened. You had a depressive episode in the face of getting fired. And how did you feel towards your boss that fired you? The patient, instead of being able to experience the full range of their emotions, instead is going to defend. Understandably so, because it's unconscious. Why would that change just because they walked through your door a few hours ago, right? So defense work deserves some special attention and some special words. It's crucial that the patient can see that he or she is using a defense, in other words, a strategy to avoid, and is not, in fact, his or her own defenses. They are not their defenses. The defenses are strategies. If a therapist challenges the defenses when the patient is identified with those defenses, in other words, when the defense mechanisms are egosyntonic, or before it's really clear that she wants to relinquish her defenses, the patient will feel attacked, and that will create a misalliance and derail the treatment. And so we help clients see how their defenses, in other words, what they do to avoid the full range of their emotions, and to keep others at a distance, how that creates and drives their problems. So that's defense identification and clarification. And then we invite the clients to let go of those defenses by highlighting the cost of those defenses, tying those defenses to the presenting complaints so that they can see how the defenses are what's driving and perpetuating their difficulties. So having their feelings, facing their feelings instead of their defenses, turning them against the defenses so that they can face what they have previously swept underneath the rug. The ultimate tool in this kind of defense work involves what's called a head-on collision. It could be a mini head-on or a major head-on, but this is essentially where we clarify reality and cement the conscious therapeutic alliance. We help the client see the part of them that wishes to avoid the resistance, and then we help them see the other part that wants to get better. And we essentially put the patient at choice. We say you can continue with the resistance all you want, it's a free country, but then this will be a failure. And then your problems, you'll take them to the grave, obviously. They're not going to magically evaporate. Or you can commit to knocking these walls down, letting go of the defenses, to face these feelings instead and come out the other end eventually and be a free man or a free woman, a free human being. And so when the client eventually, hopefully, declares their will to lower the walls, to let go of the resistance instead of holding on to it, that is what solidifies and cements the conscious alliance, that they're consciously choosing and deciding and committing to the therapeutic task that's going to be their path to freedom from their chief complaints. Now, a word again on pressure and challenge. Lest the therapist simply become a bully, pushing their own agenda onto the patient, it's crucial that any pressure and challenge occur in the context of a strong rapport, a trusting relationship. The patient's own will and volition should always be the engine of the treatment. So this is not about blowing people out of the water or steamrolling them with our own agenda. So heavy pressure and challenge, it should never occur before the client is all behind and unequivocal in her wish to let go of her defenses. Premature pressure and challenge leads to misalliances, transference neuroses, and it can really be re-traumatizing. So it's only in the context of a trusting relationship that this kind of heavy-duty pressure and challenge really can be therapeutic. So once the patient can see the cost of her defenses and clearly and unequivocally declare her will to let them go and have her emotions instead, at that point we can ratchet up the pressure, introduce higher levels of pressure and challenge on the defenses so as to weaken them and neutralize them and unlock the unconscious. And that might sound like the therapist saying, do you think that someone needs to do something about this wall of detachment that you put up here between us? And who needs to do that? And so let's see what you're going to do about this wall, this need to defeat your own goals. Still, we don't know how you really feel in here. And if you keep this up, then this will fail. Can you afford to fail in here? So you can hear there's the confrontational tone, the challenging intervention there. Now, sometimes a forceful confrontation with the resistance is needed to break through, but always remember in the context of this agreement with the patient that we have this permission to engage in this very challenging kind of work. The twin factors, Davenlu spoke of them, the resistance on the one hand, and then the unconscious therapeutic alliance on the other hand. And here's a little graph that highlights that as the intensity of pressure in the mobilization of complex transference emotions, as that increase over time, first the resistance goes up, but then it will go down. And as the resistance goes down, the unconscious therapeutic alliance goes up. Now the unlocking of the unconscious right? Once a high level of both emotional and defensive activation is achieved, and the defenses, the resistant defenses, meaning that they have congealed into resistance, transference resistance. Now, as that resistance begins to give way and is sufficiently broken down, neutralized, at some point there's an outpouring of previously unconscious psychic materials that emerges. It's like popping a giant psychic pimple. So massive, intense emotions come out and can be worked through and then put into perspective. At the end, the patient gains cognitive insight into how the defenses were creating the problems, blocking these painful emotions that had to come out and be worked through. And this cognitive insight is hammered home over and over to give the patient's ego clarity about what happened. And that's really what cements the therapeutic change, right? Without this cognitive clarity, the defenses will come back. References are some books. Where Davenlu takes center stage, Basic Principles and Techniques of Short-Term Dynamic Psychotherapy. Dr. Alan Abbas is Reaching Through Resistance, and then Personal Communications with Davenlu himself, Personal Communications with Mr. Skorman, Personal Communications with Dr. Patricia Coughlin.